The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and FlightBridgeED in their entirety. This is the FlightBridgeED Podcast, critical care and emergency medicine education for nurses and paramedics. Here's your host, Eric Bauer.
Hey everybody, Eric back with you today at CCTMC here with Kevin Collopy. We're going to talk about all things airway management, resuscitation, the difference between DSI and the air quotes rapid sequence innovation.
I like the quotes.
Yeah. Welcome, Kevin. I know we've done a few podcasts together. Love to do more. So excited to be able to do another one.
Yeah, I appreciate you having me back. It's always good to talk and think things through and kind of see what everyone else is thinking and bounce ideas. You actually just, asked me a question. I went back to the protocol and said, no, I don't have heaven criteria in here as we're going to talk about it, and give Olvera a shout out for helping develop and publish all the information on it. We've been teaching it to our staff for years, but I'm like, already, 10 seconds into talking to you about this, and hey, I got something I really should probably add in here to make this a little bit better. So it's one of my favorite reasons for talking to people about the medicine we provide.
Well, no, I agree, and I think we can learn from each other. I think it's perspective, and it's easy to get. Sometimes we're too close to something, and we miss the obvious. We've had a lot of good conversation prior to starting this podcast, and I think airway management is one of those key areas that we've done different podcasts over the years with airway management. We've done them with multiple other providers, obviously Olvera, other physicians, but I really see from the education side when I teach courses, there still is a fundamental. I think we miss the big thing, and the big thing is we've been taught for years to get the airway and get the airway rapidly. And I think we have seen over the years research like yourself, different medications that have come on board, i.e. ketamine, right? The whole aspect of shock index we're going to talk about, where there's a lot of data and literature now that shows that rushing in and providing that airway management, although warranted in many cases, we can still manage the airway from a BLS perspective, and there should be a bigger focus on resuscitation. We got to slow our mindset down. So really that is why we want to talk about this, is just talk about really your program, what you're doing, and dive into your guideline.
Yeah, thanks. I think you had just hit the nail on the head of we need to look at managing the whole patient. We were talking a few minutes ago about we need to stop just training and drilling on segments of the care and look at the whole piece. We do that in the classroom, in training, where we focus on our airway skills all the time. Well, we go perform the intubation, but we forget about everything else that goes around the patient, from getting them ready to post-airway management. And yeah, we want to focus here really talking about optimizing the patient who's not ready to be intubated, who needs an airway. But we can't lose sight of, and it's probably a future conversation, whether me or someone else, to say, what do we now do after we've got the patient intubated? What's everything else that can go wrong with the patient that we need to manage? And when we, practice, we put the blade in the mouth. Instead of having a mic drop, we do laryngoscope blade drop. I'm done. We're cool. We're ready to go. We miss some of that. And you're right. I love the air quotes, because the only part about rapid sequence intubation that should be rapid is making the clinical decision this patient's going to need their airway managed. Then we need to pause and say, how do we get them ready? And we, at our program at AirLink VitalLink, about a year ago, implemented a branch off of our RSI protocol for focused delayed sequence intubation. We actually put a stop line in here. I'm looking at it. And so it kind of goes on in RSI, the decision is to intubate. And from a hemodynamics, now the next question is pulse ox greater than 90? Is systolic blood pressure greater than 90? And is shock index less than 0.9? And if the answer to any of those is no, we pause and we go into the DSI algorithm. and we move away from your traditional approach to rapid sequence intubation or drug-assisted intubation, if you will.
No, I think that's perfectly framed. I find myself often using RSI as a term because I that's the first thing I was ever taught, right? I still struggle with the term DSI. I understand the purpose, and I love really the concept of changing it to where we just say every patient is resuscitative sequence intubation,
Yeah.
right? Because the word really reminds you that every patient needs to be evaluated from that perspective. You listed off a lot of core areas. I think shock index is huge. I think, anybody that has a tachycardic rate, you should look, and they're probably going to have a high shock index. I know. I want to know your kind of the steps on when you escalate immediately to DSI. Obviously, any hypotensive patients an automatic, I would assume. But how do you change that mindset? I think that's the thing I see is it's one thing to teach it, talk about it with your crews, but then when you put them in a patient scenario, a real life patient scenario where patients are critically injured, things are just not going right? Patients are not straightforward, and that you have other life threats. You might have a trauma patient with a massive tension pneumo. You might have multiple long bone injuries, pelvic fracture, right? You have a whole host of other issues to deal with. And I think it's really easy for maybe a less experienced provider, even a experienced provider, to get very overwhelmed in that situation.
It is, and you need to segment it. And you're right, in our protocol, it literally says simultaneous resuscitative efforts and goes down the things to do. And when a patient needs resuscitation and they need their airway managed, the focus isn't to get that airway at all costs and everything else bedamned. The real focus is to look at the patient and say, what is causing their hemodynamic instability and what do I need to manage so that I can get to that airway? We might know for an entire transport that this patient needs to be intubated and never do it, because we are going to focus on resuscitating the patient so they are properly prepared. Their body is ready to receive the induction drugs and then a paralytic. And that's something our medical director has been harping on too, of I don't care if you spend your entire flight and never intubate the patient. If you are clearly documenting you are trying to restore them to a condition in which it is safe to manage that airway, because you need to be so proficient at all of your other airway management techniques. Intubation and laryngoscopy is one tool in the airway management toolkit. It shouldn't be your first choice. It shouldn't be the only thing you know how to do. You need to be able to do everything else, from oral airways to suctioning to positioning to ventilating your patient with a BVM if necessary, to help manage that airway while you are doing everything else to get that patient ready. Because if you go and proceed with drug-assisted intubation or giving full dose sedatives and paralytics to patients who aren't adequately resuscitated and ready to receive those drugs, you can kill them. And I think we see that in the field a lot. If you've ever had a patient who they're sick, but maybe they're not blood pressure of 20 over nothing right now, and you give them drugs, and within 3 to 5 minutes, you're performing CPR. If you think back to that patient, there were physiologic processes that were going on that the drugs you gave enabled to get worse when you took away the body's compensatory mechanisms. And that's what we really need to stop and think about. How do we support those compensatory mechanisms as we move forward, and so the body can receive these drugs? Because we can't just think about our induction drug as this is a sedative, it's going to make my patient go to sleep. This is a paralytic, it's going to relax their jaw. We need to know what else those drugs are going to do and be ready to reverse those and also fix what's already going on with your patient.
Yeah, I mean, there's a lot to unpack there. I think that's exactly right. I think it starts ultimately with, I'd love to hear what really your decision making. How do your providers, how are they trained to make the decision to perform advanced airway management, right? And that's something that we've changed, and I just want to hear what your approach is.
So, yeah, do we need to manage this patient's airway? If we are teaching, or you have someone who is teaching you, intubate every patient whose GCS is 8 or less, we're really falling short. So there are a couple of reasons we need to manage a patient's airway. You have actual or impending airway failure. You have vomit in the airway, they can't clear their own airway, they can't swallow. I think a great test for that is if the patient can swallow on command and clear their own airway, they, regardless of what their GCS calculates out to, if you can tell them, hey, can you swallow? And they can go, I just swallowed, even if they can't verbally respond to you, they're probably doing okay.
Yeah.
But if they can't, and you're going to be laying them supine, you really need to think twice about it. If you have a known course of care where they are going to need to be intubated, and this is the safest time to do it, that's another reason to intubate. If you have impending or actual ventilatory failure, that's a reason to proceed to airway management. I think that's one, as a pre-hospital care system, we do okay at when we look at their SATs. But you can throw a patient whose respiratory rate is 6 on a non-rebreather, and you might get their SATs up to 95%. That doesn't mean they are protecting their airway and ventilating adequately. Great opportunity to bring in CO2 as a guide, as a tool to look at the waveform, to look at the numbers. And I'd be curious your thoughts on this too. And I don't have a hard number I give people because every patient's going to be different. And side stream capnography is not the same as closed system end tidal capnography when you have no mixing of exhaled air with the air around you. When you actually already have a tube down the throat, that CO2 is much more reliable and there's much better data on it than side stream capnography. It gives you a tool that helps guide you, and I think people have to ask the question of, not only is my patient oxygenating, but are we adequately ventilating, getting good CO2 off? And bad CO2 doesn't mean it's particularly high. I actually think if you're exhaling and their CO2 in a medical patient is 50, 60, that might be good. That might be something you want to maintain. If you've given them a bunch of benzodiazepines and their CO2 goes from 35 to 70, well, that's obviously not good. You've got a different problem there.
Right.
And then the last reason I think to throw into it, and then like I said, hear your thoughts on CO2 and how people can use that, is it needs to be done for the protection of the patient or the crew. That's in our guidelines. It's in our protocols as a reason to intubate. Protection for the crew, if you have a truly combative patient who is fighting you, they are a flight risk. They are saying, if you put me in your vehicle because of a head injury, because of whatever reason, I am going to try to slash your throat. Well, that might be your safety, clear safety reason of you might need to sedate and intubate them for your protection. But it can also be for the patient's protection. I intubated several years ago a 13, 14-year-old, forget exactly how old they were, that had been shot in the chest with an arrow. He was ventilating fine. GCS was 15. Very scared, but he has an arrow sticking out of his chest. I'm going to put him in a helicopter. I know he's going to go to the OR. It's sticking out the back. I know we're not pulling out this impaled object. But I did it for his own safety because as we started moving him, I was going to have to go cut and clip that arrow at some point and didn't want him freaking out when we came at him with tools and didn't want him to accidentally grab it. Didn't want him to do something that made him worse. And we felt that protecting him with this procedure was going to be the safest thing possible for that patient. So I think there is a real point to, we're going to do it for patient protection, but you have to be able to articulate that.
Yeah. I mean, you bring up a lot of points. I think I try to bring it into 3 core areas, and then, they're very similar to what you said, right? Is we have definitely moved away from GCS less than 8 intubate. And I think that is great. I think you got to make it simple. You got to be able to make it to where there's not a lot of opinions. So I love, what's their ability to follow your commands? What's their ability to basically control their secretions, right? 2 simple things. And the third one for me is, what's their clinical course? The last example that you just gave about the arrow, GCS 15, he was talking to you, responding to you. You knew, though, that he was going to have a road where he's going to end up in the OR. You knew from a safety standpoint, you had to load him in a helicopter, etc. So you made a decision based on a clinical course. His airway was fine. It was protected. He was protecting it, but you still took his airway. So I think you can say those three things, and I think they're exactly what you said. Make it simple for the crews, right?
Yeah.
Make it to where they have to make good clinical decisions. And I think the clinical course aspect just brings objectivity. Each provider is going to have maybe a different level of comfort. I am a big advocate to always teach to be proactive, not reactive. That's something Olvera taught me a long time ago, right? Be proactive, reactive. I love that term. And I think we've talked in other conversations about, you can have a very experienced crew or provider get into a situation where they were very proactive, and then all of a sudden you lose an airway, dislodgements happen, and that same crew now becomes reactive, and things don't go good, right? We go same crew, but now we have a completely different outcome because now we're reactive. We're not ahead of the game. So I'm a big advocate to teach that we stay ahead if possible.
Every crash airway that occurs because it's after patient care was initiated, there's crash airway when you walk in and the patient's in airway failure. We're going to have those. But your patient was doing fine and now they're apneic in flight. We probably missed something, and every single one of those cases should be looked at for opportunities to learn. We don't want to say we did something wrong, even if we made a mistake. I think making a mistake and doing something wrong are two different things. And it's okay to say we made a mistake, but we have to learn from that and look at those. And you're absolutely right. That we do the same thing of if we intubated late, if we missed it, we need to look at it and say, how did you do that beforehand? I think one of the easiest ways to also think about it is, while no one likes to be questioned, no one likes to be challenged, it is completely okay and should happen every time you drop off a patient you've intubated in the field that a doctor's going to look at you and say, why did you intubate this patient? And you need to be prepared to say, why? It's not saying you were wrong, but they need to know, did you intubate them because their airway was failing? Did you intubate them because their ventilatory ability was failing? Or did you intubate them because you knew what was going to happen and it was the safest thing to do it early? And they're going to go, okay. They asked me, why did you intubate this 13-year-old kid? I intubated him to give him the safest possible care during flight. He never had an airway failure. He never had this. And they went, great, thanks. Because now they knew GCS was okay. They knew where he was neurologically. That's the mental checklist the docs are trying to go through of, okay, what else do we have to manage when you've managed the airway that we don't know? And I think we all need to be able to be ready to articulate why. And the answer, my protocols said so, or because they're a trauma patient, or they were a stroke, those are the wrong reasons. We need to be able to articulate why clinically. What was the clinical reason for it?
You bring up a great point. It's very easy in that situation, the way you framed that, even though that was framed very, very normally, that a provider easily could take that as a reference that they're being questioned. And that was not the case. And I think you articulated that perfectly, that it's simply a mental checklist they're going through. And it is how we have to communicate on their level, right? We have to understand that. And I try to share that with people, explain your rationale. If you perform a chest decompression in flight, you had a simple pneumo and you started seeing some clinical signs that, maybe your PIP spiked, or, ultimately make the best decision at that time and explain your rationale, right? Nobody's going to fault you for that. And just have the critical thinking behind that. Chart your critical thinking. So whoever's reading the chart, they understand why you made that decision. I do want to touch on the whole ventilatory failure, right? End-tidal CO2, right? What is the correct answer?
So clinical respiratory failure. If you're looking at the nerd answer, because try to be a nerd and at least pretend to be on TV.
Yeah.
If you run an ABG on your patient, one, if you've got enough time to run an ABG to decide what you're going to do, you probably have to pause and say, do we need emergent airway management now? You still might, But that needs to be a pause and a check to say, if I'm going to run labs to figure out what I'm going to do with an airway,
I agree.
You got to pause and think. But on a critical care interfacility transport, you need to look and say, is my patient who's been on BiPAP, who's been on CPAP, who's been on some sort of support, are they deteriorating and in clinical respiratory failure? So why it's so important to look at an ABG is because your SATs could still be okay. You could still have SATs of 90, 91, 92%, but you really need to look at your PO2 and your PCO2. So clinical respiratory failure is a PO2 of less than 60 and a PCO2 of greater than 50. It's interesting. I just recently saw an alternate approach to that PCO2 is it has increased from your baseline assessment. So if you've been trending your patient over time, from about an increase of 10 to 15 millimeters of mercury. So if you see it go up, you really need to think about what's going on with your patient. And so even if you haven't hit 50 yet, if it's gone from 30, they're tachypnic, they've been blowing off their CO2, and now it's 45, so that's still technically normal, but we need to pause and say, that's a huge change in our patient. Maybe they truly are better and they're just slowing down their breathing, or maybe they're tired and they're actually getting worse. So that change is important too, because it's also, I might have a PCO2 of 60 on a COPD patient and say, I want to let them go for a while, because if I intubate this patient, they might never get off a vent, but now they go from 60 to 75, we're getting worse.
Well, so you bring up a great point, and I think for me, it's very easy to say respiratory failure, ventilatory failure is defined as anything greater than 50, right? And that could be a determination to intubate. I think we have to start with clinical judgment, right? Gestalt.
Absolutely.
And identify what does your gut instinct say, and maybe if you do have the ability to check labs, check an ABG, maybe that's a confirmatory type of test, but your clinical suspicion should already be going down that road. I don't think that I would simply intubate a patient. I would say less than 1% that I would clinically make the decision to intubate somebody just because their PaCO2 is greater than 50. I definitely think that I would be more apt to, as a confirmatory piece of information, to say, hey, you know what? I do have a PaCO2 greater than 50, but I also have a PaO2 less than 60. Okay, that right there, I would definitely probably be more apt to make that decision. But again, it comes down to I should already have an assessment and that gut instinct to say this patient already needs this. And let's be honest, most programs in the United States do not have point-of-care testing. Right? And so you have to make those decisions without those pieces of information.
And so I think one of the great reasons to have it, and where I think we can make this real for everyone, is if your PO2 is less than 60, we could still put you on oxygen and your SATs could be 95%. But if you look at how quickly that patient's going to desaturate, they have no oxygen reserves in their system. So they're going to very quickly deteriorate. And this might be why, if you don't have it, if you have had a patient who you pre-oxygenated, you got their SATs up 96, 97%, and you go to start intubating, and within 2 minutes, they've desaturated to 70, well, that patient's PO2 was in the gutter.
Yeah.
So you didn't have it, but now you know, and that's why we're looking at this. So I actually look at it, and especially if your patient's still mentating, okay, they're in respiratory failure, this is a great time to say, let's try some things first to get them ready to be intubated. This might be a great patient to put on CPAP if you have it, or BiPAP, or a high flow nasal cannula with 100% oxygen to help drive oxygen into them to help them get better while you're getting ready to maybe think about intubating, while you're getting things ready. Maybe your approach becomes, instead of, okay, I got to intubate them, let's put them on a non-rebreather and get everything ready. Well, hold on, we know we're likely to go that direction. Let's put them on BiPAP. Let's watch and see what they do. Because we actually, in medicine, often have patients in clinical respiratory failure, but you look at them and you're like, they're still awake, they're still talking to me. Let's try some things and see if maybe some less invasive support will help them get better. And maybe we can help them improve with an hour or two of BiPAP on a high flow nasal cannula. And we don't then have to go that direction because we're actually to give them meds, give their body time, let them adjust, and they can improve. That's, I think, when we started talking about when you think who to intubate, numbers are there. They're a guide. They're a checkbox in the toolkit as you're thinking about your patient. But you can't make your decisions based on a singular number. And your most critical patients, if you think about the numbers of respiratory failure, those are the ones who, if you rush to it and you do it wrong, are going to deteriorate so quickly on you, which is all the more reason when you say, hey, clinically, let's look at them and go, oh, geez, I need to intubate them. They're obtunded. They're breathing 45 times a minute. They can't swallow. I need to optimize this patient because if their PCO2 is in the toilet, their PO2 is in the toilet and their PCO2 is through the roof already, and I give them a bunch of drugs that make them even sicker in theory, potentially, I could take a patient whose body is still holding on and cause them to rapidly deteriorate in front of you.
Yeah, no, one of the parts of using CO2 as a guide, and I think that's often, that term is used very loosely. We teach these in courses. We talk about respiratory failure, and respiratory failure really is looking at the ventilatory side. Just like brain death determination, it's not the SpO2. The SpO2 stays fine. It's the CO2 that climbs that is the determining factor. But there's definitely a difference between putting the critical thinking behind the number, right? And I think we've both said that in a way. It's easy to give a new paramedic, a new nurse, that number and say, respiratory failure is defined as anything greater than a CO2 greater than 50, right? That doesn't mean that patient needs to be intubated.
Right.
And I think that there's definitely that's the difference between hiring somebody or you or I, as we went through our career, learning a specific number and then learning the critical thinking behind applying that in patient care scenarios, like real patient care situations.
I think it's more important to think about the numbers and use them to say, if I've looked at you and you need to be intubated, this is probably what's going on in your body. And if I don't do this right, that's what's going to get worse. So the numbers, if I'm thinking about it as a learner, don't tell me to make a decision. I want to know the numbers to have the background knowledge. Okay, I need to intubate this patient. This is probably where they are hemodynamically. This is probably what's going on in their body right now. I need to manage that before I also do this really invasive intervention.
Yeah.
Before I paralyze them and put a tube down their throat. I need to fix what's probably going on in the background. I don't think we think about that enough. We too often think, oh, they're sick, they need an airway. Let's get their sats up, mate, and intubate them without thinking, what else is going on clinically in this patient? And how is that going to impact what I need to do to get to my ultimate goal of intubating? But I need to manage all these other things first. And I think that's so important to think through that step as a clinician.
Well, yeah, I'm just sitting here thinking, we spent quite a bit of time on this first decision-making piece. And it reminds me that we're asking ourselves as providers and our crews to make a lot of critical decisions with a lot of stimuli from a lot of different sources very rapidly.
Yeah. So easy
honestly,
to become overloaded. And that's why we so often talk about what can we do to cognitively offload information, and why do you need to drill things so much so that it becomes muscle memory to you. Like, you said something yesterday in your talk here that struck a chord with me when you said you need to go play with your ventilator every day so you know all of your alarms, so when something happens you reach over and you know what to do without even thinking about it. And it's not saying you need to be an expert respiratory therapist. That's not what you were saying. You were really saying you need to make it automatic so you don't have to think through, oh my God, there's an alarm going on. What's wrong with my patient? How do I figure this out? So that while you're managing your patient, you can reach over and go, oh, this changed. I need to make this adjustment. That it just becomes natural for you. And I think that was such a profound statement while it was about, in a niche talk about how you were managing a pediatric patient on a vent. It was such an important statement to say, offload that. So if you bring that back to Airway, how do we cognitively offload? You need to not just practice put the piece of plastic in the throat all the time. You have to practice this whole procedure so you know where all your RSI equipment is. When you're bringing out the drugs, you don't have to think, where's my 10 mil syringe? Where are my needles? Where's my this? If you're thinking through all of that, you're filling your brain with stuff we can offload. And then next, that's why so many systems, mine included, have implemented RSI checklists. So you don't have to think through what are all the things. We're putting it in front of you to help think through all the common pieces we need to manage in a hurry to help free your mind to think about all these other critical interventions. So yeah, there is a lot. And the one message I'd want to leave people is, if you as a team have made the decision you have to manage the airway, stick with it. Don't change your mind unless the patient miraculously sits up and says, I don't need this anymore. Once you've made the decision, don't second guess yourself. Get everything ready to say, what do I need to do this well? But it is also okay to say, I need this patient needs to be intubated, and we assess it and go, they still need to be intubated, but this is going to be so difficult, I need more help. We can't forget that piece. We can't just say they need to be intubated. I'm going to go do this without assessing your patient to say, okay, they need to be intubated. How hard is this going to be, and how bad could it go?
It's no different than taking a test and changing an answer, right? Mm-hmm. Your little gut instinct inside your gut, your stomach, it will always keep you out of trouble. I think it's very easy to go against that and have external factors that might, sway you one way or the other. But I think that's one lesson I've learned is, your gut instinct is going to tell you the truth, and you need to follow that. And I think that's exactly right. Don't change your mind. If you're trying to talk yourself out of something, that should be the red flag. I think the whole aspect of checklist, if you've listened to our podcast, I've definitely got into this debate with Verkest, with Jarvis, with different physicians. To say that I'm a somebody that doesn't believe in checklists is probably incorrect. What I truly think happens, I'm not saying across the board, I think checklists are amazing. I think they're great in the context of confirmation. Our pilots use them every single day, right? I think it's important. I think from a provider standpoint, it's important from a confirmation. But I also think there's definitely an area that I have seen personally where you have some providers, we'll just say individuals, people, we're not going to say who or, I'm just generalizing, that uses that as a way to where they don't have to know the information. And right. and that is very alarming to me.
It's dangerous.
It's very dangerous, right? And it's no different than I have always had a photographic memory with numbers, okay? And I think back before cell phones, I had everybody's phone number memorized. I'm sure many people listening did as well. I probably have 10 phone numbers in my phone now that I have memorized. And if I had lost my phone, and I would be in trouble, right? And the point is, if we don't exercise our mind and we start relying on technology to the point to where we lose the ability to critically think, we're in big trouble. And that's where I've always tried to push back with Verkest and with Jarvis. It's not that I disagree. It's that there has to be accountability, that the provider understands why they're doing what they're doing, and they're using the checklist to confirm. Would you want a pilot to sit up in the aircraft and, they can turn the aircraft on, the master on, the engine 1, engine 2, but they can't fly the aircraft, right? You got to be able to apply and understand why.
In my opinion, an effective checklist is short, concise, and fast. And you said it great. You said it's confirming you're ready. So the checklist doesn't walk you through. When I see the checklists or I've seen a couple where it lays everything out and then you set everything out on it to get ready. Well, that's not a checklist. It is cognitively offloading things, but it's telling you everything you need to do to get ready. But to me, that takes too long. Our program's RSI timeout checklist is 10 questions. It's a challenge and response checklist to say, are you ready? We've done everything. We've gotten set. Yeah. And it's before you push the drugs, it's stop, pause, 15 seconds. Read through it. It's on your badge card. Yep, we've got everything ready. We agree. Go. Because it's not telling you what you need. It's hitting the high points so that everyone stops. Just like in the OR, we take a timeout before we start. Pause and say, do we all agree we have everything we need? We're ready. And it gives you the opportunity for everyone to be quiet for a moment and let one person say, Eric, do you agree? Kevin, do you agree? Bob, do you agree? Yep, we're all ready. Let's go. So yeah, that lingering question that other person has that they've been afraid to ask, it gives them that opportunity to voice up and say, well, what about X? Oh, did you notice your patient's SATs are now 50%? Whoops, no. I got so tunnel visioned I forgot to go back and look. That, to me, that's what a checklist should be for, at least in our patient management sector.
Well, and I think my rationale and where I've had these discussions is, we can have our phone die, right? We could have our phone die. We didn't charge it. We could have a checklist maybe that's laminated that all of a sudden gets lost. We leave it at the hospital. It's left in a chart book at the hospital. And then you're now toned to another flight. And then you get on that flight and you've so relied on that checklist to critically think for you that now you're lost without it. That's always been my fear. And I use the cell phone analogy as an example, right?
It's a very well taken point of you need to be able to perform the procedure without it.
Right.
It is a safety tool that's in place, but if you lose it, you need to know everything you need to do well enough that you are very confident performing your interventions without it. If you're thinking to yourself, I need that checklist to know what to do, you need to pause and go, I need to practice this more. I need to know it. It's your point to the ventilator of it so well. You don't need to look up how do I manage the alarm. Your hand knows where to go to say, to look at the vent and say, what's going on with my patient? This alarm is going off. What's the alarm? What is it and why? And you already know it without having to look up, high pressure alarm. Start with dope. You shouldn't need a sheet of paper to tell you that.
Yeah. No, I think we've covered a lot of information. I think the key point of this podcast is really to put a spotlight on resuscitation in the airway management scenario and make good clinical decision. Make sure you and your partner are on the same page. I think the more that I do this and am part of education, I think stress inoculation training is really important. I think I can't tell you how many cases I review from a medical legal aspect where I see phenomenal crews that previously have done everything perfect, but then they get into a reactive state where now they're stressed, and the same procedures that they excelled on previous, where they were in a proactive mindset, are now reactive, and things don't go correctly. So, I definitely think that training in those high stress environments are something we should do more of.
Absolutely. We are taking all of our team members through the sim lab to practice DSI. And it's not all going to be the same straightforward patient, and it can't be when you take them in where you walk in and the first thing they have to do is manage the airway. It's got to come up later on, and why we're doing it that way is so we're already building stress. So we already have to build management and things in there because that's what's going to happen in real life. So let's put all that in there to try to create that stress as realistic as we can in a safe environment so that you as providers have the ability to practice and think through this. So you said we really want to focus on resuscitating our patients. So now let's kind of move it forward. So we got the assumption we've made the decision we need to intubate the patient. And where we first started talking about is, okay, what does that mean? So for whatever reason, we've decided we have to intubate. What I think are 3 really good questions to ask, and what we've built into our protocol is, in our clinical questions is, what's their shock index? Is it high? What's their blood pressure? What's their pulse ox? And you want a shock index less than 0.9. You want a pulse ox greater than 90. And you want a blood pressure of greater than 90. 90 is 0.9. Easy to remember the nines. And then if you don't have any of those in our program, what we're saying is stop and go to this additional protocol. Not that you need to look at it. You should have this memorized, is what we teach. It's there if you need to look at it, but you should know it well enough to say, okay, I have a problem. Let's look at the patient and say, which one of these am I managing? If they're already hypotensive, well, I need to focus on volume resuscitating and really think about what's that underlying cause. How do we fix that? Simultaneously, let's look at pulse ox. What do we need to do to bring it back up? I think the big things, options in that are BVM, mask ventilation. And if you're going to mask ventilate, especially if you're getting ready to intubate, please put a PEEP valve on your BVM. There's no reason to not preset them all up with a PEEP valve attached. It's only going to help you. It's not going to hurt your patient. And it's going to help you manage that. And the other thing that we've put in is consider using non-invasive ventilation. So put them on a high flow, put them on CPAP, put them on BiPAP to help manage that patient, especially if they're breathing on their own. Take advantage of the patient's physiology, give them the intervention, let them breathe to help improve their oxygenation. It takes you beyond just, well, let's put a nasal cannula on them and a non-rebreather and really think through how do we maximize their ventilations. The one that gets a little bit tougher to really algorithm out, if you would, is high shock index. You really have to think through why is their shock index high and what do we need to manage. It's easy to look at a high shock index if their blood pressure is already low. If they have a systolic of 50, they're going to have a high shock index. It's, okay, they have a high shock index because they're profoundly tachycardic. Well, we need to look at each other and say, okay, let's look at what's going on. Let's really think through this. Is it they're just in an SVT? Is it, well, they're in compensated volume shock. Their body's compensating and it's a compensatory mechanism. Well, that might take you back to volume. Or is it something else? Is it pain? Is it an allergic reaction? Is it someone bolused them with a ton of epi? You have to think through what's going on and what do we need to do to manage that before we move forward. That's a part of that resuscitation. And we kind of have to dissect those all one at a time. But when you're thinking through managing it, and this goes back to, we're putting a lot on the provider, you need to manage all of these nearly simultaneously. So it really takes a team to do that.
Yeah, I mean, I almost would challenge maybe you and your program. I mean, I would almost hypothesize that the majority of patients that your crews encounter and when they do decide to perform, DSI, resuscitative sequence intubation, that maybe we should approach every single patient with that mindset. Every single patient should just across the board have we should have the mindset that we assess the resuscitation core areas that you laid out. I mean, I don't know if there's any disadvantage of doing that.
There's none other than, and it's not really a disadvantage. I think we just have to acknowledge it's going to force you as a clinician to take more time. So that means it's the right thing to do, and you have to communicate it with your partners, with whomever else you're going to be intubating around, whether it's scene calls, hospitals, we are going to be spending more time on your scenes at your facilities when we are managing these patients, and here's why it's the right thing to do. But we need to get that messaging out. And yes, you're right. Every patient, we should be evaluating these. And our protocol is not designed to say, manage them lane 1 or lane 2, and you don't have to go to lane 2 unless you have one of these criteria. It's designed to say, you should be looking at this. Because if you're asking those questions, what's their pulse ox, what's their blood pressure, what's their shock index, you're already thinking about, do I need to resuscitate those every time? The way we've set up is that DSI protocol really is, here's the kind of the best practices or where you should start your management when you do need to intervene on these. You need to reassess volume every time you're going to intubate. That doesn't mean you have to give them a unit of blood before you intubate every time, but you need to be thinking about it.
Right.
What we've kind of put in here is, if that's the problem, it's okay to give that unit of blood before you intubate. And that's what it's designed to do. Not say you don't need to do this, but you need to, here are the buckets, and here are some things to really think about when you are asking those questions. But I think you're right. We can all be more intentional to say, ask the question, and here's why. Here's why you're asking that question, instead of, well, if here's the problem, go to the protocol. Here's what you need to do. Rather, when you're asking the question, here's the context we're really trying to put it in. And that's what the goal ultimately in the highest performing systems would be. That becomes automatic. You don't have to stop and look at each other and say, what should we do? We're already looking at it, and that's just part of we need to intubate and we need to do these things to get there.
Yeah, and we could go so many ways on a podcast like this. I think it's really easy to, I don't want to say cookbook medicine, right? We have to be very, very, I've said in previous podcasts, 50 Shades of Grey. And there's something that, there's a difference in saying, hey, you know what, we have a patient that has an SpO2 of 90. That's the cutoff, right? And saying that is a hard and fast. And so when you say that to me, I start thinking, well, where is that SpO2 pro placed? Is there a shock state? Is there SpO2 latency, right? Is that a true number? Is there a good pleth, right? And so my mind goes to that, but in maybe a more inexperienced new paramedic, for example, we'll just use as an example, you or I, when we're first credentialed, I don't remember, right? That's been 31 years ago. But I don't remember, did I have that mindset? Did I have the why behind it, right? The substance behind it. That comes with making mistakes and learning and educating, being educated. And so, there definitely is a difference of telling somebody, hey, this is that threshold we're gonna use. Why are we using a shock index of 0.9? What do we do if the shock index is greater than 0.9? Well, you laid out some key areas. Hey, we got to resuscitate. We got to make sure our volume is there. But what's the ramifications of maybe ketamine administration with a high shock index? What do we do with that? Right? Those are things that I know you have laid out in your guidelines very, very well. And those are key areas that truly make a difference in the end. Is understanding why do we do what we do, and I love playing the why game. Something I learned from Alan Wolf is ask a simple question. Well, what fluid are you going to give a patient? Well, I'm going to give normal saline. Okay, why? And get that provider to get down to the nuts and bolts of why they're doing it. Make sure they understand why they're actually doing what they're doing. Well, and like you said perfectly earlier, well, it's because my protocol says. No, I don't want to hear that. I want to know that you know why you're doing what you're doing, because that makes a better critical thinker. And ultimately, I truly think that's what saves lives. Critical care medicine, to me, education is not always you doing some fancy procedure or doing something that is cool. Yeah, we get to do some cool stuff. We have new equipment. We have pretty amazing guidelines that are expanded. For me, as an educator or administrator, I want to know that my providers are able to make good critical decisions. And maybe it's knowing what not to do. Maybe it's being all right with what you're seeing because you have a broader understanding. You know what I mean?
Yep. You're hitting the nail exactly on the head, and it's a great point of, you can't just look at the number and go, well, that's the number, and not realize that you're looking at the pulse ox while the patient's got a tourniquet on that arm.
Yeah.
It really easy something to miss, especially if you've got a bunch of people helping with the patient. You might not realize that they've put it there. You need to look at that whole picture. You also might have a patient that you're never going to normalize. So you might have to get, to the point where you accept we are going to intubate a critically ill patient who already is and is going to remain until we get them intubated or until we get to the next phase of their care in this really bad state. Our protocol says our goal, our ideal state would be a pulse ox greater than 93%. But what I want everyone to know is, well, why is that? Well, because if it's 90, 89 is when bad things start to happen. We know at a pulse ox less than 90, we have worsened outcomes. Mortality starts to rise, risk of complications starts to rise, risk of brain damage starts to rise. And in TBIs, a singular episode of hypoxia significantly worsens their outcomes. And so why do we target 93%? Well, we know, and we want greater than 93% because we know the rate of oxygen decline in that 93 to 90% range is exponentially faster than your rate of pulse ox decline when you are 94, 95, 96, 97, 98. As you go higher, that drop from one to the next is going to be slower than once you hit 93%. So you have to look at that and say, well, what am I really trying to do? And am I going to get there? And you might have a patient that you're never going to get over 90%. You know, you might have someone who's got the inhalation burns, and the highest you're going to get is 84% until you get them intubated on a closed circuit and have high PEEP. And, you know, you're really controlling them with a vent because they already have a lot of lung damage. And you don't want to get so paralyzed by a protocol that says don't intubate until their sats are over 90. Well, it says this is your goal, but if you might never get there, but you want to show you've tried these things or you've thought through them as a clinician and you can articulate it, why you moved forward when you did, and what you tried to mitigate ahead of time. We don't want to just say, well, that means if I know I'm never going to get the sats up, don't try. Well, you still want to try to optimize your patient first, but you need to know what it is you are trying to optimize and why and what the value for that patient is. You know, why do we want their blood pressure up? Well, we want their blood pressure up because it's better for them. Well, no, it's here are the drugs I'm going to give, and I'm going to actually take their blood pressure back down. So I need to play the balancing act ahead of time. And if I start bad, it's only going to get worse for my patient. But if I don't know which cause of that hypotension I'm treating, I'm going to just blindly give a bunch of saline to the patient. And if they're acidic and I give normal saline's pH is not normal, folks. It's, you know, it's profoundly acidic, and it's what, 5.56? I'm trying to remember off the top of my head,
like
and
that.
You know, not without looking up. It doesn't matter what the number is. It's just it's not great. So if I have a septic shock patient, I might not want to reach for normal saline. So I don't want to just say, well, the protocol says give a fluid bolus of normal saline. No, it really should just say give a fluid bolus of the appropriate fluid for your patient. And you need to be able to articulate which one you picked and why, because it's right for the condition the patient's in.
Yeah, I mean, we really have covered a lot of stuff. I think it just comes down to understanding how important resuscitation is. That we have really changed our mindset. You go back to one of the earliest FlightBridgeED podcasts I did. It was called the Platinum 10. It was a study done by Ken Palazzo, and just talking about getting off the ground on scene flights in 10 minutes and the importance of that. And a lot of our patients in the scene flight realm, not all, but a lot of them are trauma patients, and we have really focused on getting that airway. Airway's number one. We know that there's been a big paradigm shift where circulation is now in front, right? Make sure we stop any major hemorrhage, and then we can go to airway. Doesn't mean airway can't be managed from a BLS standpoint, but I think there's definitely a lot of supporting evidence to say, hey, even if you stay on scene an extra 10 minutes, if your patient doesn't arrest and you can get them to definitive care, you're doing the right thing. And it comes back to honestly the competition in the HEMS industry. And you have multiple aircrafts in an area, and one of them can get off the scene quicker. The other one sits on scene for 20 minutes, right? And I've definitely heard it. I've seen it where that crew that sat on scene for 20 minutes, maybe they were providing better care. Maybe the outcome was better. We don't know. I'm just saying that loosely, but there's definitely a shift. I'm not saying you sit on scene for an hour, on a scene
Right.
flight, right? I'm not saying that. But what I'm saying is you got to use good judgment and do what's right for the patient. And sometimes we get tunnel vision, we go too fast, we miss the obvious, and the patient suffers as a result.
Double-edged sword, and that's what we were teaching everyone, and we'll continue to. You don't want to get stuck in, okay, I'm in DSI, I'm resuscitating my patient, I'm going to sit here on a patient you're never going to resuscitate. You have to recognize when you need to do this while moving to a facility that can appropriately manage the patient. If they are hemorrhaging internally and the only way to stabilize them is to get them into the OR, sitting on scene is not going to help. At the same time, if you haven't yet, you will eventually have a patient that if you move them too fast, and as soon as you lift them onto the other cot, they code. That's the patient you need to learn to recognize and say, I need to resuscitate them here before I even move them to try and get them into a little bit better state, because they're so unstable that if I move them too fast, if I don't do this, they are going to deteriorate and they can't wait. It's that fine line of that gray area of finding, when do I need to do it here? When is this an ongoing procedure that I need to resuscitate throughout my care? And if I get them to the point I can intubate them, great, but I might never get them there. And how do I pick and choose those? And you have to drill it. You have to learn it. It takes so much experience. We can't talk through all of those situations. But you're right. I don't want you to rush off scene. I don't want someone to be, I have to get off scene in 10 minutes or I'm going to get in trouble. If it's right that you need to manage the patient where they are. Simultaneously, I never want someone to think, I have to get all this done before I leave because it says I have to do all this first before I go to my next step. No, you can do that on the way as well.
Yeah. And
that's the critical thinking when you're managing, we're just talking about airway, but it's really the whole patient. Maybe if there's no other learning point, the takeaway message on this becomes, you can't talk about managing the airway without talk about managing the whole patient. You can't separate them, nor should you separate them. And you can't think about your airway management without thinking about how you're going to manage the patient in their entirety. If you are separating them, you're probably setting yourself up for an eventual failure.
No, amazing points. I think in the end, slow down. If we can help you, if you are redesigning your guideline, again, I would advocate that. This is just my view, right? This is not, I think, I'm not speaking for anybody else. I truly think that we should treat every patient as resuscitative sequence intubation, right? We should just across the board assume that they need resuscitation, evaluate them from that perspective, slow down, train to that mindset, train in a stress inoculation environment, to where when we do, unfortunately it happens, get into a situation where we could be very reactive, that we are able to respond accordingly, slow ourselves down, and we don't have a poor outcome. Again, man, I appreciate your time. I know this has been a long podcast, but hopefully this was enlightening, and you can use some of these little tidbits that we talked about. As always, you can always reach out to me, eric.bauer@FlightBridgeED.com. You want to give your contact?
Yeah, easiest way to get a hold of me is on Twitter or LinkedIn, probably. So at KT Collopy on both of them. Or my email is kevin.collopy@novanthealth.org. That's really long, which is why I say just get a hold of me on social media. If you got a long question and we need to talk about it through, I'll just say, here's my email. Shoot me an email and we'll figure it out from there.
Yeah, and I'll put your email in the show notes. And show notes are always at the very bottom of the podcast. In the description, you can just hit more and it'll be there at the bottom. So again, man, I appreciate it.
Yeah, this has been fun. Hopefully everyone's got a couple of tidbits they can take away and apply to your practice. It's always I think the goal of, when you talk through something, the goal is that you guys can take something away and apply it tomorrow. And you said help you through protocols. Rarely do I hit a home run and there's a protocol right the first time. We even drill those. We test and we let people try it and then say, we need to make changes. Because what's crystal clear in my head was mud to everyone else.
Right.
And that's okay too. So if you're writing your own protocol, and you're helping write them, everyone will want to hear that I know of that writes, and we're always open to feedback, and they can always get better. protocols are an evolution. And that's probably a whole separate conversation, so I'll stop it there.
Oh, you're good. All right, guys. Well, again, if you have any questions, reach out, and thank you again, and we'll talk to you soon.
This has been a production of the FlightBridgeED Podcast, leading the way in pre-hospital critical care and emergency medicine education.